humans, how's it going? Susan Ruth here. Thanks for listening to another episode of Hey Human Podcast. This is episode 198, and I did a FaceTime with Dr. Rendi Murphree. She and I have been friends for years. I think she's brilliant. She is an epidemiologist, currently director of the Mobile, Alabama Health Department. She works with the Alabama Public Health. She's formerly with the CDC. She was there forever and did a great job with the CDC. She's also worked with the Tennessee Department of Health. She's a retired captain in the United States Public Health Service. So, as she put it in the interview, when you think of the Surgeon General, that is her commanding officer. That being said, we talked about all sorts of things. Obviously, the coronavirus, because that is a very hot topic right now. We talked about STDs. We talked about HIV. We talked about tuberculosis, Ebola. She worked with Ebola cases. Really fascinating life that Rendi has led. Again, I cannot speak more highly of her. She is a wonderful person, inside and out, and smart as a whip. We have had so many fantastic conversations over the years. And so I was really happy. I for a couple of years now, I've been trying to get her on the show, and she's so busy. And so here we are, and I'm really excited to share this with you. The usual stuff, social media, Hey Human Podcast at Instagram and Facebook. If you want my personal social media, it's Susan Ruthism, Facebook and Instagram and Twitter. You can email me, susan@heyhumanpodcast.com. Rate and review Hey Human on iTunes, wherever you get your podcast. It really helps to get those ratings and reviews. So if you have a few minutes, please do that. That would be great. You can find more about me at susanruth.com. There's stuff about my art and my music and any acting-y stuff I'm going to do. Acting-y stuff, that is an official term. But if I have any performances or anything, it will be on susanruth.com. HeyHumanPodcast.com is, of course, the main website for Hey Human. Makes sense. And on there, you can find a links page. And this episode particularly, I think it's great to go to the links page because all the stuff that Rendi and I talk about, I put a bunch of information for this week's episode. She mentions a couple of good places to look, especially if you're freaked out by the coronavirus. So those will be there on the links page. She also is open to getting emails from you, so I'll make sure that info is on the links page as well. Or you can, of course, always email me, susan@heyhumanpodcast.com, and I can pass that on to her. I want to thank those of you who have donated to Hey Human. I really appreciate it. Your support is humongous and helps keep the podcast alive and well. And if you want to donate and you haven't had the opportunity and you think that it's a donate-worthy show that you want to hear it keep going, the donate button is there on the heyhumanpodcast.com website. So please check that out. I appreciate it. Okay, well, enough of all that stuff. Let's get into this episode. And thanks for listening, everybody. Here we go. Dr. Rendi Murphree, welcome to Hey Human. I'm so excited to have you on the show. This has been a long time coming.
Yeah, it has been a while, so I'm really glad that we pulled it off finally.
Yay! It's been a while since I've seen you, since the Nashville days.
Yeah, I think about 2 years, maybe 18 months.
That's a crime.
Yeah, because I think the last time was at 51 or 51st or whatever, that restaurant with the dog park.
Yeah, the dog park restaurant. I like that place. Yeah. Wow, well, it's great to see you.
Good to see you too, Susan.
Thank you for being on the show. You retired recently from the CDC. Explain what your role was there.
Well, it evolved. So it started out, my first job with the Centers for Disease Control was as a research microbiologist. So I had worked in foodborne microbiology in an academic institution just out of graduate school, and then went to work for CDC in Fort Collins, Colorado. So out there they have the Division of Vector-Borne Infectious Diseases, who knew, in Fort Collins, Colorado. So I started there as a microbiologist working on developing assays for borreliosis, which is primarily Lyme disease, but there are some other Borrelia that cause or are thought to cause infection. So that's where I started, was in Fort Collins as a microbiologist. And then I learned about this world of epidemiology and U.S. Public Health Service, and those were agencies and terms I'd really not encountered in my life before. I was raised in the South, remember? So I was like, that's really what I want to do. I want to be an epidemiologist. And so I went to school at Colorado State, got a PhD, applied to the CDC Epidemic Intelligence Service, was accepted, which is great. That's kind of the proving ground for any, bona fide disease detective, is you got to go through the CDC Epidemic Intelligence Service. So I did that, and then I worked the last 10 years of my time with CDC as an epidemiologist. I did have, during that time, just a 2-year little side jaunt over to Chicago O'Hare Airport, working with Global Migration and Quarantine for CDC. So like I said, I've done a lot for the agency. But yeah, I retired after 20 years being in the U.S. Public Health Service and at the CDC. And
now you are still active in the biz.
Yeah. So after, air quotes, retirement, we moved to South Alabama so we could be closer to family. And I'm very fortunate now to be working at a local health department in South Alabama. And I work there as an epidemiologist still. I think I'm the only one at this agency, which is shocking. But again, it's rural Alabama. And then I'm also the director of the Bureau of Disease Surveillance and Environmental Services, which is a big job, a big girl job. I was not expecting to have this much responsibility in, like I said, air quote, retirement. But I'm super lucky to have landed this position, and I'm learning a lot about the agency and about how to be an administrator now.
And you're also retired military, correct? Or are you active?
Yeah, I retired from active duty in the U.S. Public Health Service. Lots of folks don't know what that is, or they say they've never heard of it. But if you know the Surgeon General who warns you not to smoke, that's our commanding officer. There are probably 6,000 or 7,000 active duty officers in USPHS strewn around the U.S. primarily. And the service really is primarily to provide health care to indigent populations. So we have lots of clinicians working at the Bureau of Prisons, at the Indian Health Service, with Customs and Border Protection, ICE, providing health care to detainees at border crossings. And then a lot of other folks like me, scientists that work at CDC or NIH or Health and Human Services, that sort of thing. So, so I retired from active duty. So no more uniforms every day, no more hair in a bun every day. I am now in the land of the civilians.
Is that a naval branch?
So that's close. So it actually started very close with U.S. Navy because when the service when they first started hiring physicians to care for merchant Marines, we're all sort of grew together. And so Navy became sort of the folks on the ships and that sort of thing. And the Public Health Service became the arm of the service that would put vessels under quarantine when they would come into ports, also would provide health care for, like I said, for the merchant Marines and eventually other services. And so it's similar, but a different service. Like, for example, the Navy is under the Department of Defense. So they are armed and trained in combat and that sort of thing. And U.S. Public Health Service is under the Department of Health and Human Services. But we also provide health care for the Coast Guard, for example. So very simple. Go ahead.
Go ahead. Sorry.
No, I was going to say one of the things that's super cool about my new position is the building that I work in is like 200 years old. And it used to be it started out as a merchant marine hospital and a quarantine hospital for U.S. Public Health Service and what became the U.S. Navy. So I feel really sort of close to my roots in many ways by working in this building that's been around for so long and has its roots in U.S. Public Health Service. It's really cool. We carry C ranks just like the Navy does. I retired as a captain, which is an 06 in the Navy. So admirals are 07s, if that kind of puts into context sort of the rank. I feel very fortunate to have reached that rank before I was eligible to retire. It's really great. So all the pay and the rank and the benefits and all of that is the same as the other armed forces.
What got you interested in epidemiology? Why the shift once you realized that it was out there?
So this goes back really to high school, and I don't know how the demographics of your followers, but
all over, everywhere.
So when I was a kid, I wanted to be Quincy. So Quincy was a forensic pathologist on TV, and that's really what I had my eyes set on. But like I said, I came from a pretty poor background, a very rural area, and I just did not, out of high school, couldn't find my own path to medical school. So I went the route of microbiology, which really satiated that sort of investigative nature in me to sort of find out, have a research question and then just go about trying to answer it. So when I got to CDC as a microbiologist, like I said, I'd not even heard of the field of epidemiology. I didn't understand what a disease detective was, or that was a real job, and so I just thought, wow, being a research scientist, I got a lot of enjoyment and fulfillment out of that. But with epidemiology, I really had the opportunity to work more with people, with populations of people, and not so much bacteria and viruses and petri dishes, right? So that's really sort of why I decided to shift gears, and it was just a natural fit for my interests. It's just been a really great career and continues to be for me.
What do you think about how do I put this? Does what you know make you hypersensitive to germs, or do you think it's given you a more lax attitude?
It has definitely just sort of numbed me a little bit to any concern about germs. As a laboratorian, I had several accidental exposures in the laboratory where I would have to go on fever watch for, a period of time. One time I was working with some frozen listeria, which is a foodborne pathogen, and I flicked some of it into my eye, and I had to go on fever watch for that. And then once at BC, I opened a centrifuge and it had wild type dengue in it, and so I had
dengue fever.
Yeah.
Oh jeez.
I had to go on fever watch for dengue virus for a while. And then I was working with Francisella, which is Francisella tularensis is the bacteria that causes tularemia. And I was working with a not bad version of Francisella, and it spilled onto my hand. And so I had to go on fever watch for that. So
didn't Francisella just win an Oscar? That sounds like such a name of a person.
It does, doesn't it? It's a good thing I don't have any children, because they may have wound up with just the oddest scientific names.
Yeah, absolutely. I remember way back. So you worked with Ebola. Did you go?
I did.
Yeah, talk about that, because I find that fascinating. Were you scared, knowing? I mean, I suppose you have a lot more knowledge than the average bear. So, and for the regular folk that are reading the news, terror sells much better than calm. And I remember when you were heading that way, and I thought, well, I think she's going to be fine. But it's got to be a little insane.
I think that, first of all, they don't send us unless we are very well trained and, fit for working in those environments. So, I have to sort of rely, as all responders do, rely on my training and my instinct and my experience to make sure that I don't get myself into, a situation where I might be exposed to a communicable disease or, be put in danger. Most people overseas that travel, they're more likely to get into a car accident than, get an infectious disease. However, I do not worry. Usually leading up to it, there's a lot of excitement. It's like, this is what we've trained for, right? Like, let's go. So sort of like a firefighter running into a burning building. It's like when there's a big outbreak, like we all want to go. We all want to go. We all want to help. We want to figure out what's going on. We want to stop illness and death. And so that's usually how I feel going into a deployment. And then once I'm there, it's all about listening and learning and trying to figure out how, you can help the jurisdiction that you're sent there to assist, because often often the governments have decided that, we need CDC personnel here, or we need FEMA people here, not the local residents. And so you have to be very sensitive to, going into those environments and trying to help people, right? They don't always look at it as, U.S. person, woman, man here to help me. So it's a little tricky. So that usually takes some time. And then usually by 4, 5, 6, 8 weeks, I'm exhausted and ready to come home. Mm-hmm. And I say, I'm never doing it again. And then as soon as I'm rested, I'm like, yeah, I'll go to Haiti, whatever it is. So it's a cycle, but it's usually a very, very exciting time for epidemiologists, disease detective people like me. It's like chasing ambulances.
Yeah, that is a weird thought to think that you're more excited when the world is a little off kilter. Were you boots on the ground dealing with Ebola patients? Were you in the lab?
So I'm not a clinician. I'm not a licensed healthcare provider. So I was not in the Ebola treatment units. I worked with the county government to try to provide some technical assistance to them. One of the things, I did a lot of stuff, but one of the big things I did along with another couple of people from CDC was to evaluate their dead body teams. And I know that sounds rather harsh, but that's just, what they were. They were these teams of folks, locals, who would go out and, retrieve dead bodies and move them to locations that had been secured to try to stop the transmission of Ebola. Because, in practices around burial and handling decedents, the body of decedents after they pass is very different in different cultures. And there's a lot of hands-on, preparation, mourning, that sort of thing, which was propagating the spread of Ebola. And so I followed lots of dead body teams and retrievals to try to see if we could, make some recommendations for improving the safety of their practices during body removal. So as you can imagine, that was an extremely difficult time. So I have a couple of photos where I'm standing, without personal protective equipment next to the spouse, of a person who had died from Ebola and been in the house for, 5 days because there just weren't enough teams to come and retrieve them. And looking back on those photos, I think, wow, I probably should have put a little bit more distance between me and the family member that had been, living with this person who died from Ebola for several days. But that was a pretty unique experience. I did go into several Ebola treatment units, but mostly just to talk to sort of intake, that sort of thing. And then another thing that I did with the government there, which was really important, was to try to go about in the countryside to identify sort of respite centers where people who probably didn't have Ebola but needed to be tested to rule out could go and stay while they were waiting testing results, because there were so few treatment facilities. We were trying to keep, worried well out of Ebola treatment units where they could potentially be exposed, and, provide other safe spaces for them to, receive hydration and evaluation that were out more in the countryside. So that was a really fulfilling part of what I did while I was in, during the Ebola response as well.
Let's talk elephants.
Oh my goodness. So elephants is, Yeah, it's a crazy story. To me, I still get calls about this, Susan. Like, probably at least once a year, someone calls the elephant lady and wants to talk about.
It's quite a story.
This study that I did back in, what was it? I think it was 2010, maybe 2009, 2010. So at the time, I was a brand new, EIS officer. So I was in that 2-year program that CDC, has for doctoral level people to learn how to, investigate and diseases. And I was living in Nashville, Tennessee. I'd been assigned to the Tennessee Department of Health. And it just so happened that one of my advisors had a connection with the elephant sanctuary in Nashville. Well, not in Nashville, but outside of Nashville, Tennessee. And so we've gotten reports that some of the workers at the sanctuary had converted. That's kind of a lingo that's used with tuberculosis, had converted for TB. And so let me sort of just quickly explain that. A lot of people think TB is like, an ancient disease and we don't have it anymore, but we do have tuberculosis, both introduced in the country through travelers and also spread person to person in the United States all the time. And the cheapest way and to screen people is to do this thing called a tuberculin skin test. So basically, they put a little bit of TB antigen under your skin, and then 3 days later, you have it checked by a healthcare provider. If your immune system has been primed for TB, for tuberculosis, then that antigen reacts and it enlarges and inflames and hardens, and so you convert from a negative to a positive. So that's why it's called conversion. So we heard that people at the sanctuary had converted to TB. So we got permission for the sanctuary. The sanctuary is several thousand acres. They only take in, they have a lot of elephants, but they mostly take in elephants that have been, on tour or mistreated or have diseased, and they provide them just this lovely existence. It's like a respite or retirement home for elephants that have served their time in chains and circuses and in zoos and traveling, tents. And now they have been rescued and they are very well taken care of at the sanctuary. So we got permission from the sanctuary to come on site and try to see, what's happening here. And so through an epidemiologic study, we determined that some elephants there were known to have been infected with tuberculosis many years prior to arriving in Tennessee. And they were shedding tuberculosis probably through their trunks, as they, trumpet or cough or sneeze. Maybe shedding through, urine or feces, who knows. And then the workers were not adequately protected because the ventilation system was probably not efficient in protecting them from TB. And so if you can imagine a huge barn with 4 to 6 elephants in it, and they're, every day workers have to go in there. They wear these suits to try to protect them, and they're pressure washing, the barn every day and trying to make it really clean. And by doing so, they're, probably re-aerosolizing tuberculosis and then going into the room next door, taking off their protective equipment. And unbeknownst to them, some of the air from the barn has gotten into what they thought was a safe area. And so they breathed in TB and converted to TB. The good thing is in that investigation is that none of the workers, the elephant caretakers, none of them got TB disease. They did convert, meaning that they had been infected with TB, but they didn't get TB disease. So they all took antibiotics to make sure that they didn't get disease, and they did not. So that's, I guess, the success story, the silver lining. But it was pretty landmark because there had been reports here and there about the possibility that this could happen. But in many people's minds, this was kind of like the first, not a clinical trial, but the first observational study of, an outbreak investigation associated with elephants. So we could demonstrate statistically that those folks got TB from those elephants, not from someplace else in the community or, from other humans or things of that nature.
And you also, did you not pick it up? Yeah.
I did. That's another picture that I have where I'm pretty sure I have a photograph that I was taking of the workers, because I was there to observe what they were doing so that I could try to figure out, where the breaches in infection control were happening. And so, it wasn't really until it was kind of too late for me that I figured it out. Hopefully we protected other folks from, and again, I did not get disease. I took, I think, 6 months worth of antibiotics to protect me from infection. And the crazy thing about that is that during that 6 months of antibiotics, I got deployed to Haiti following the earthquake. I went about 4 to 6 months after the earthquake just to do like shelter surveillance. And while I was there, I had to take anti-malarial medications. And I ended up like just all of the meds, like my liver enzymes spiked, and I had to come off of it so that, my liver didn't suffer. So, so I've never gotten an infectious disease that I know of at work, but I nearly started getting some liver damage by taking prevention antibiotics and anti-malarial. It was just crazy.
Wow, 6 months of antibiotics. Your gut must have just been desperate for happy bacteria by then.
Yeah, luckily the treatment practices have changed, and we have much shorter courses of antibiotics for TB infection and TB disease these days. So it's gotten a lot better in the 10 years since I was involved with it.
And tuberculosis is making an uptick here just within the city. All the encampments and things, they're finding that the TB is on the rise. There's a lot of especially in the United States. And you had, when we were making arrangements for this, you had said that you were heading to a conference about syphilis. And I thought, man, all these things that we sort of quieted down are now spiking again.
Yeah, it's really concerning. Yeah, the TB thing, now I work in Alabama, and just in this jurisdiction that I work in, where there are about 450,000 people that live in this jurisdiction. In 2018, they had 2 TB cases. In 2019, they had 11.
Which is a huge uptick. It doesn't sound like a lot of people, but if you're looking at it in terms of science, that's a huge uptick. Yeah,
I mean, very, very concerning. Part of it is easier detection. The tests for detecting TB infection and diseases are getting, any diseases actually, they're getting better. And so part of that uptick might be that we can detect it faster, sooner, better. But part of it is just, I think, prevention is a hard activity to sell. And we rely so much on what I call kind of like rescue medicine. Like, okay, I'll take a pill to make me better, or I'll take a supplement to, keep me, to cure my infection, or I'll get surgery, or, take insulin because, I can't control my diabetes with exercise and diet. But those prevention measures, hand washing, vaccination, where the, sexually transmitted infections are concerned, wearing condoms, it's really difficult to sell those very easy prevention measures and to keep people doing it.
I think, too, with the fact that now HIV isn't a terminal illness, people, for the most part, unless you can't afford the extraordinarily expensive medication, that they're now looking at that as not as big of a deal, or, and I read somewhere, and I don't know if this is true, you probably know the statistics, that Atlanta alone had 1,000 new cases of HIV over the last couple of years. Is that true? It seemed alarming to me, but
I don't know about Atlanta, or about the number. But yes, in the last 5 years, like U.S. wide in the South is more heavily impacted than others. We've seen an uptick of HIV cases, and the great thing about HIV is that we do have amazing treatments now, and now it's about getting on treatment and getting your HIV levels below detection, because if you get your HIV level below detection, they call it U means you, undetectable means untransmittable. So if you can get your viral load down, then you don't have to worry about passing HIV to your sexual partners, but you still can pass syphilis, chlamydia, and gonorrhea. So you can't stop using condoms altogether if you're having promiscuous sex, because these other sexually transmitted diseases, are still out there, and they're out there in big time supply. So
I can't remember if it was Anthony Jeselnik or maybe I can't remember. It was a male comic. I can't remember who it was now. Maybe it was it might have been Russell Brand. It's somebody. I'll have to look it up. And I apologies to the comics of the world, because I'm about to lay this on someone. It might not be them, but that said, to cure most STDs with antibiotics takes about 10 days. If people would just stop having sex and take in it, if everyone across the world who's sexually active stop having sex for 10 days, take all your medicine, we would wipe out everything. But nobody's willing to do it.
No, because there's such a thing as reinfection. So we'd have to do that like once a year, like
it could come up once you've got it. Sure. Like if you are right.
Yeah,
but once you've killed it within your body, you don't get it again until you've been reinfected by another partner.
Right.
Yeah.
But Susan, that happens way more.
Mm-hmm. And it's interesting that you say in the southern states, where abstinence is such a big part of the vernacular, and as we all know, that actually does not work. To tell people just don't have sex doesn't work. Religion doesn't stop sexually transmitted diseases or pregnancy that must be frustrating as a healthcare person.
Yeah, I mean, it is a little bit, but I think that, some of those, when I was a federal employee, that some of those big policies, I think, impacted me more than they did maybe at the state level or at the local level, because I think the closer you get to that personal interaction with people, the more you realize that even though there may be like, a presidential policy against or for abstinence or whoever's in office, right? If they pull funding or whatever, same thing could apply to, gun use and those sorts of things. When we're out there at the local level talking with people, like we're just talking to a person, right? Like you need to, let's try to avoid unwanted pregnancy. Let's try to avoid, STD transmission. Here's some condoms. We try to just do the right thing when we're on that sort of, local level, trying to implement, trying to implement prevention measures. And trying to stay out of that sort of, national conversation about policy and that sort of thing.
Yeah, well, that makes sense, because I think for a lot of people, especially on the local level, they have zero cares about what's going on in the policy place.
Yeah, well, and the other thing that we really have to remember is that, someone testing positive for HIV or another STD, it may not be the most difficult thing in their life right now. I mean, they may be dealing with housing needs and hunger and, keeping their kids in school or, so it's important that we sort of have that broader context and realize that, yes, to us, it's the most important thing, but in the lives of these folks that are affected, it may not be, what they need help with at this moment in time. So a lot of managing, people who have or who are at risk of contracting a sexually transmitted infection, a lot of it is about helping the whole person, not just sort of, addressing their infection or their sexual practices.
Well, and another thing, too, that you bring up, the at risk, is I think there is this great misunderstanding that only particular people get an STD, and a bug doesn't care who you are.
That's true.
A bug doesn't see color, doesn't see religion, doesn't see sexual orientation, does not care.
Yeah, right. And that is very true for the other sort of more common things out there that we're dealing with right now, like influenza, those sorts of things. Like we just have to keep telling people, like, wash your hands, like, because, get a vaccine. to try to protect yourself, from getting flu, or if you do get influenza, from protecting you from getting, so sick that you have to stay home for 10 days or potentially hospitalized. So, like I said, it's and anyone is like, subject to getting some of those things. So it's something that, we have job security.
Yeah, for sure.
We don't have a lot of funding, but we have lots of work to do.
Well, I look at something like the coronavirus, which I think we should talk about, because I think most of the news is really getting the fear thing out there instead of the calm thing out there. And that's probably a huge thing that you in your profession have to go up against all the time. But you're far more likely to get the flu than the coronavirus. I mean, and it's frustrating because now it's just another reason to hang your hat on xenophobia or, whatever, too. Let's talk about coronavirus a little bit, because I think people want to, straight from somebody who actually knows what they're saying, not just some talking television head wearing a nice suit.
I mean, people ask me, should I be concerned? Should I be concerned? Talk, around here. And so in South Alabama, I can't say that there's no risk, but I can say that there is, no known risk to the general population. So those, to folks outside of, this office, that sounds like the same thing or mumbo jumbo, but we have to pick our words very carefully. So, if you haven't traveled to mainland China, or if you don't know anyone who has, or, then you shouldn't worry yourself about getting coronavirus. You should be concerned about, crossing the street safely and, protecting yourself from flu and making sure that you're reheating your leftovers and protecting yourself from foodborne illness. But, we are closely watching what's going on because, we've been preparing for a potential pandemic flu for many, many years. And the amazing thing is that some of the plans that have just been very esoteric, really kind of like, writing a movie script, right, for the past 10 years, not really knowing if we would ever actually need to implement them. Like, many of those things is what CDC is doing now. And so it's a great, not trial run, because we're actually doing it, so it's going to be a great test of the pandemic flu plans that we've been working on for decades. So some of the things that CDC has been doing, like issuing federal mandatory quarantine for hundreds of people, like that has not happened in our lifetime. It's unprecedented. And so, that's shocking to people, and it's why it's hit the news so much. And if the plan works, if they can keep it out of the U.S. or becoming a, community spread in the U.S., then we will all be like standing up and applauding and making donation, right? Like thanking, our gods that they did it, and they did it early and they kept it out. So I think it's probably too early to know if what the U.S. has done is going to knock the curve down or delay the curve. So when we think about a curve, like if you count the cases, the line keeps going. Today it's 10, tomorrow it's 50, the next day is 100, right? That line keeps going up and up and up. And at some point with every epidemic, it starts going down, down, down. And so what they're hoping to do is either delay the peak of that curve, or make the curve shorter, smaller than it would be if we had absolutely no interventions. Does that make sense?
Yes.
If your listeners can kind of visualize that.
Yeah.
If it works, then great. It will be like a great demonstration of early prevention measures and some rather severe and unprecedented prevention measures. What's going on around the world, it's a little bit too early to tell. You've probably seen on the news, they're saying, right now, influenza, seasonal influenza, you have about 0.1% of those result in deaths. For the new coronavirus, COVID-19, it's around 2.5-3% of illnesses result in deaths. For MERS, it went up to like maybe, 10 or 15%. For SARS, it was somewhere around 35%. But, we couldn't calculate the percentages for that until it was over, or while it was happening. So we can only calculate for coronavirus what the death rate or, the severity of it as it's going along. So is it going to stay around 3, or 2 months from now? Are we going to see that it's slowly creeping up? It's just too early to know how it's going to compare with the other 2 really big worldwide coronaviruses that we have dealt with before, SARS and MERS. But we'll see. And also, I just want to say there's so much confusion about this. Like, I've seen on social media, oh, everybody, you're not going to believe this. My 2-year-old just tested positive for coronavirus. Or, hey, my Lysol jug says on the back of it that it kills coronaviruses. So let me just try to help explain that. So since the 60s, when coronaviruses were first recognized by scientists, there have been 4 coronaviruses that have been identified that have been circulating in our populations for decades, and it causes something called the common cold. So we have coronaviruses. They are out there. They can be killed with Lysol. If you test positive with one, it is not the new coronavirus unless you were tested by CDC. So just want to sort of set the record straight on that.
That's good. Yeah.
It's important.
The other thing, too, is just it's a numbers game. You think about there are a lot of people in China, a lot, a billion people, and this tiny, tiny percentage, and they're in rural places. It's harder for them to get to medicine and even understand what's going on necessarily and get to the doctor. Because like most of us, what happens when you get sick? You go, I'll be fine. Go to the hospital. No, I'll be fine. It's just a cold. It's just the flu. Well, in some cases, of course, that's the difference between life and death. Dehydration, I imagine, is a big part of it.
It is. I mean, I heard this comparison, which really helped me sort of get my arms around Hubei province and what it was like for the Chinese government to shut down, Hubei province and say nobody goes outside, nobody works, no schools. So Hubei is about the size and population of Florida. And so, they have a communist government, so they can do things differently than the U.S. But for the Chinese government to shut down a population and jurisdiction the size of Florida to try to stop, the transmission or movement of this virus around the world, I mean, that is really huge. And kudos to them for doing it. We'll learn, in years of reflection, whether they should have done it sooner or not. There'll be lots of debate about that as the years, lots of scientific papers about all of that. But I think that, just for the U.S. to sort of realize the magnitude of what they are dealing with over there, it's just ginormous. And we may see additional hospitalizations, because they, as we have more hospitalizations and, resources and staff become, slim and overworked and supplies are low, I mean, that might contribute to a rise in the number of severe cases and deaths. So we'll just have to sort of keep a close eye on it and see how things work out.
Let's talk about anti-vax for a minute.
Oh, good Lord.
Yeah, I know that's a huge subject and probably extraordinarily frustrating to somebody like you.
Yeah.
Firstly, when we were kids, we got, 7-8 shots over a course of, and now there's a lot more. So I think for a lot of people, they think, oh my God, why so many shots? This isn't necessary, this, that, and the other thing. The bottom line is, you're not just protecting. This is my opinion. I could be wrong. But in my opinion, you're not just protecting your family by getting your shots, but you're also protecting the surrounding families, all the people in your school and all the people at your work. And it's not just about you,
Yeah, well, I'm glad you think that way. I think that, there are a small population of people who don't agree with that. Don't agree that they have a responsibility to help protect the herd. That's what we call it, herd immunity, right? And so they don't think that they should vaccinate their kids if it's against their religious philosophical, personal
Yeah, it gets
conviction.
complicated when it's that stuff. Yeah, for sure.
Yeah. And so, are there rare side effects of vaccination? Of course. Some people faint. Some people have, sore and redness. Soreness, redness. Some people, get a vaccine and may run a fever 2 days later. That might be, associated with that shot. But this idea that vaccines cause, autism, scientifically, there's no basis for that. That it's not an important part of improving public health, those sorts of things. I have a difficult time sort of even chatting with them, because once they made up their mind, it's like science doesn't matter. And so I'm a person that believes science and data, and I also believe that I have a responsibility to help protect my community. And my community might be my church or my school or my workplace. And so I buy into that mentality. The folks that don't believe in that maybe should, and that's their right. It's their personal conviction. If they don't want to vaccinate their kids, they don't have to, but they should also think about maybe homeschooling.
Yeah,
so that their children are not out in schools and that sort of thing. Susan, I think that our generation, I'm in my early 50s, I think we take for granted good health. I mean, we have not lived in the days of polio and widespread measles and rubella. And we just, we've not had cousins and family members, get sick and die from things that are perfectly preventable these days. And I think we, as a generation, maybe sometimes become a little bit arrogant, maybe not respectful of, what our grandparents went through. And that really makes me sad, because I hope that it doesn't take another, polio or, continued measles outbreaks and those kinds of things to help people realize how important vaccinations are.
Yeah, and we have had measles outbreaks.
Oh my gosh, I worked a measles outbreak in Tennessee when I was there, and we had only, I think, 5 or 6 cases and something like 1,100 contacts. Like, so many people had to keep their kids home for 21 days, and because they had not been vaccinated and they didn't have proof of vaccination. And so we had to say, sorry, you can't take your kids to school. You can't take them to daycare. So then you got parents that are trying to, that they maybe have 2 working parents. So now they've got loss of income because they can't take their kids to daycare, or they're scrambling to get family members to come and help. And it's just a really, really bad situation. I mean, economically, it makes no sense not to vaccinate your kids, because if something happens, they're going to be told to stay home.
Yeah. I had the flu on New Year's Day, and I went to bed New Year's Eve before midnight because, boring and whatever. Woke up in the morning and just vomited all day long. I was sick as a dog for 4 days. It just came out of nowhere.
Yeah. But that is the way you can tell flu from colds, because you have that very rapid onset, and it's not sniffling, sneezing, right? That is not the flu. It's this rapid onset of fever, feeling very tired, a cough or shortness of breath. This just like feeling hit by a truck kind of thing. So, a virologist or an immunologist would be great at that question. Yeah,
do you think that we have the potential? Now, again, you're not a virologist, but this is a question that you may be able to answer. The flu of 1918 that wiped out a third of the population on the planet. Do you, if not a little more, is that something? I did a deep dive on that flu. I was very curious about it and learned that it really struck, quote unquote, healthy people that normally a flu wouldn't because when you hear flu, you think old people, babies, they're screwed. Yeah. But in this case, it took down people in the prime of their life and their health and their vigor because it scrambled the body's understanding of, it attacked itself, basically. It went into hyper mode of trying to, protect itself, and people ended up drowning, and that kind of thing. Do you think something like that is potentially out there? Or do you think we are now at a place where we can monitor and do what you were talking about, swoop in and contain?
Yeah, I would like to think that we could avoid a repeat of something like 1918. Now, having said that, there are some caveats. I think the United States and some other, developed countries would have a better chance of, trying to avoid a repeat of something like 1918. But it's quite possible that if something like that came back, we might not be able to protect underdeveloped or developing countries in the same way, because what happens with a pandemic is then the entire world is battling it. And so, if it's just a localized epidemic, then the US or Europe can go in and help and support responses in other countries that don't have as much, like we did for Ebola, right? So if the countries don't have the infrastructure to care for people, if it's a focal outbreak, then we can, bring in resources to help. In a pandemic situation, the big countries might not have the capacity to help underdeveloped or developing countries in the same way. And so I worry that they could potentially suffer casualties if we had a big new superbug influenza kind of thing. The last few times that it's happened, it's not been fun, but we've sort of, ridden it through and gotten past it. So like, for example, H1N1, when that virus jumped up, first noticed in Mexico and then in Southern California, that flu started totally off season. Like it was recognized, I think, in April, and it was just totally out of season, which is probably one of the reasons it was recognized so quickly. But that flu, H1N1, the pandemic version of 2009, that strain still circulates today. Like that is the majority of our influenza A infections that happen during seasonal flu now. So while when we first saw it, it was a big deal, and we had, a year's worth of worth of response. Now we're sort of past it, and we're able to, now it's just sort of part of our, unfortunately, part of our flu mix most years. So I don't expect that we would have a repeat of something like 1918 with a natural bug, but I do worry about some parts of the world that aren't as equipped as we are to help ourselves.
Yeah, and of course, we won't even get into biological warfare and all that kind of fun stuff, because that's a whole other ball of wax, and probably not your forte either. Yeah, I think thank God for places like the CDC, who I imagine have deep wells of every kind of contagion that they know of and its antidote. I would imagine that that's kind of how it works.
Yeah, it's funny because somebody asked me when I was talking about coronavirus recently, they were like, really? CDC is the only one that has a test? Why? I said, novel coronavirus. No one in the world has seen it before, including CDC. So it's brand new. We can't prepare for everything. So yeah, that's why they're the only ones right now that have a test, but this too shall pass. But yeah, occasionally things do come up that we've never seen before. What we try to do now with advanced biologics is try to build, I saw this really cool graphic recently where they were saying, well, we can build on vaccine work, particularly now with sort of, man-made vaccines. You can take components and move them around a lot easier with man-made vaccines than with biologics. And so if we have, something that's similar, then we can get to a vaccine sooner because we're not having to start from scratch, right? We can take components of this man-made vaccine and that man-made vaccine, and then tack on the new part of the new virus. Does that make sense?
It does.
So they are really getting better at doing those kinds of things to help us get to vaccines, to antivirals, to treatments.
And HIV is a perfect example of that because, it took some time. And then there was the few asymptomatic HIV patients, and I'm sure they descended on those folks and said, "Can we have some of your blood, please?"
Yeah.
It's a fascinating subject. And then you talk about, a new virus, but is it new? Is it already out there, and it just so happens that maybe some animal passed it to some human, or vice versa? Or what?
It had to be out there somewhere.
Yeah, it doesn't just hybrid out
But it wasn't causing illness in animals or humans. So you can't imagine the infinite number of viruses there are probably out
so many.
there.
I'm so sorry to anyone listening who is a hypochondriac, because it's the worst thing to hear.
Your hypochondriacs should wash their hands.
Everyone should wash their hands and sing happy birthday in your head while you lather twice, right? Happy birthday twice. That's what I read online.
I've seen that too. I've actually started washing my hands more lately.
I would imagine. And the people that think that just Purell alone is the thing, it's not. They say that it's not as good as the washing of the hands.
Exactly. It's warm water, it's soap, and it's friction that gets you to the cleanliness.
Sorry, that got me a little turned on. I don't know why.
I said that just for you.
Oh, thank you. What are some maybe websites people can go and look at, things that I put this again in quotes, the everyman, the regular person that's just trying to live their lives, that doesn't have a science background? Where can they go to do a little reading, a little research, things that I can put on Hey Human Podcast on the links page, just to ease people's fears, perhaps?
Ooh, well, I mean, we are you're talking about for coronavirus?
For anything. Sure, coronavirus. I mean, the CDC.org, of course, is a great...
There's this is not going to alleviate their fears necessarily. I have seen this coronavirus dashboard that Johns Hopkins has published, and it is amazing. I've even seen some TV broadcasts use it as like their backdrop, their blue screen kind of thing. That is really, really cool. Just make sure when you go on the CDC website that you look at the sort of information for the public, because you could get lost for days looking at the information for healthcare providers, the information for public health, the information for the maritime industry. I mean, it's just nutso.
Well, I'll get the John Hopkins link and stick it on Hey Human. And so
that is a really, really cool thing that I saw, which is kind of neat.
And if people want to find you, how might they do that? Or are you unfindable for what you do?
No. I mean, they can email me at my Gmail account if they want, or they can email you and you can send it to me, whatever.
With questions or concerns or... Yeah. All right. So anybody listening, if you have a question for Rendi, send it to me at susan@heyhumanpodcast.com and I will send it.
So what's the favorite joke you've heard about coronavirus?
The one I've heard the most, of course, is with the beers. It's just Coronas.
Yeah.
So
right.
Yeah.
Well, have you heard that coronavirus comes with a Lyme disease?
Oh man, we didn't talk about Lyme disease, and I've had some friends in Nashville that have had that, and talk about a tough thing to get rid of.
Yeah, true Lyme disease infections are difficult. I try not to talk about Lyme disease because it's highly controversial. And
yes.
I was a Lyme disease expert for 8 years and felt very attacked on many occasions, again, for trying to believe data and science. And it's difficult because there are a lot of really sick people that are struggling and you want to help them get better.
What's wild about Lyme disease, too, is that it presents differently depending on the person. It's not like you have the flu, you're probably either going to barf or poop your brains out. You're going to have a high fever. You're going to feel like crap. Your skin's going to hurt. And then 5 days later, you're going to feel better and drink a bunch of Gatorade and do your best, or whatever. Maybe get some Tamiflu. But the people I know with Lyme disease, it's some have really achy joints. Some have migraines all the time. Some have blurry vision. Some, there's just all these different presentations from what I can gather, because I play a doctor on TV.
I can tell.
Yeah. And is that incorrect, or would you say that's a fair assessment, or?
I think so. Yes, there are several different manifestations of Lyme disease. So, the easy one is just the rash that you can take some antibiotics and it resolves. And then there are, like you said, some later stage manifestations, the, neurologic Bell's palsy, neurologic conditions, headaches, that sort of thing. I think where it gets a little fuzzy is that there are a lot of folks who then have, aches and pains and other associated symptoms long after they were diagnosed with Lyme disease that they try to associate back to that original infection. And I think the reality is that it's unlikely that they have had infection that long, but perhaps what they're experiencing are some potential lingering effects of a cleared infection. Does that make sense?
Yeah, because it leaves behind, as you were talking about with the elephants, it's a shedding.
Not so much. I think that this idea that you have a Lyme disease infection, like the live spirochete in your body for, multiple years, 5, 7, 10, 20 years, I think that is this is Rendi Murphree's personal opinion, is that is highly unlikely.
Can diseases, it's an interesting question, because Lyme disease or not, can't diseases sort of hide out in a person's body waiting for the opportune moment to strike?
Some of them can. Yes, there are some that can, like tuberculosis. It's very well known that if you get a tuberculosis infection, that it can just stay dormant in your body for a really long time. And then should you experience some, attack on your immune system, or your immune system gets weak for some reason, or maybe no good reason, it activates in your body and then causes disease. Yes, yeah. That is not the model for Lyme disease. Interesting.
I find it all very fascinating, and I find you very fascinating, and have adored you from the moment we met, because you and I have the coolest conversations.
Yeah, I feel like I have that Rocket Man, job. It's all the science I don't understand. It's just my job 5 days a week. So I feel very, very lucky to have my Rocket Man job.
Well, I think they're lucky to have you. You're very bright. I'm curious, when you go into, I should have asked this earlier, but when you go into other countries where, let's just say, women aren't regarded as highly as men, how do you work around that little situation?
Yeah, it's tricky, Susan. Like it's all about trying to build trust, and usually my approach to doing that is really using a servant leadership model, where I just try to have some small wins early on with providing assistance or advice and that sort of thing, and sort of slowly building that trust. But you're right. There have been many instances where, especially initially, I've had to go into meetings with, male counterparts before, I sort of was able to start, kind of speaking out on my own. So it's tricky. Yeah. But that's, we get some culture briefings on that generally before we're shipped out. But it also just takes, a kind heart and a patient heart for someone like me when you're going into that situation, just to know that, it's sort of like, when in Rome, it just, live as the Romans, but, try to be as effective as you can in creating, building trust and creating change while you're there.
Yeah. And for all the girls and women listening, to know that you really said, I want to do this thing, and you got this thing. You are who you set out to be, regardless of the fact that you said that you came from a socioeconomic background that maybe wouldn't have supported normally a female pursuing what you have pursued. And I think that's a huge thing to just shine a light on.
Yeah, I appreciate that. I really am as surprised as everyone else that I have had such a phenomenal career and was able to attain, a PhD and am doing this work, this great work. I just am so lucky and proud to have gotten here. And I try to give back. I mentor or talk with a lot of junior scientists or folks who want to work in the field of epidemiology. And I always take the time to chat with them or, talk about my career path. And because it was circuitous. I didn't have a straight path from high school, to PhD. It was a winding one. So thank you for that acknowledgement. And try to live your dreams.
You are the best.
All right. Thanks, everyone.
You have got to be so busy right now, so I really appreciate you taking the time.
You're welcome. I'm glad that we were able to do it.
Thanks for listening, everybody. Bye. Okay. Rate and review Hey Human on iTunes or wherever you listen to your podcasts. Thank you.